Okay, good morning, everyone. Uh, my first observation when I came to the US yesterday was that everyone was looking relatively very calm, not stressed. And I was wondering whether we outside America are actually more stressed about your election than you are. Huh? But possible. So it's nice to see you all looking very calm, and even though I know that the situation is really very. Thank you for putting this together. The talk that Dr. Ramaswamy gave and team sort of set the stage for the reason for the need for this kind of collaborative cross-cultural studies. But actually, the Intrepid research program was started on the basis of some previous epidemiological study, especially the one that was conducted by the WHO several years ago, in which they showed sort of similar prevalence or even incidence of schizophrenia across different settings, but also show that the conditions had a better outcome in developing countries. So that was really the basis for the initial attempt for us to put this study together. That we've given the title International Research Program on Psychosis in Diverse Settings, which we have now conducted. We've conducted phase 1, phase 2, and now we are in phase 3. The phase 1 was conducted over 3 years, really more to sort of set the stage and develop these instruments and the methodology. And then we went on to conducting the second phase, is Intrepid 2, with the broad aims are listed on this slide to compare the incidence and presentation in the 3 settings where the study is being conducted, to explore the 2-year cause and outcome and the pattern of help seeking and the impact of the illness, as well as to track some other both antecedents and comorbidities, and also consequences of this condition, particularly physical health problems. So we are recruiting. We're now in Intrepid 3, which is really basically to follow the Intrepid 2 sample. And track the 6-year outcome. But the incident study itself, where we recruited the people from these various contact settings in those 3 places. We use popular sector, by which we meant people who might not have been taken to anywhere to hospital, who are sort of in their various homes. We use public mental health systems, tracking all the new cases presenting in those. And as you might see, you will see later on, we will also very importantly track cases from traditional and faith healing facilities in those settings. These are some of the pictures of where we did this, and a particular catchment area, Kanchipuram in India. That was the area that we chose, mainly rural, outside of Chennai. In Ibadan, we use both local and urban areas around the metropolis of Ibadan, like a catchment area around that. And in the third place was in northern Trinidad. And these were the cases we identified. So the catchment area we selected on the basis that we should have population at risk of at least 500,000 people, adults. And so we were able to select, to identify this number of cases in those 3 catchment areas over the 2-year period. And as you can see from that, most of the cases in Trinidad were identified from professional treatment settings. In Ibadan, sort of equally distributed between professional and folk, that is traditional faith healing homes. And in India, you see that as many as 80% of the cases were identified from neither of those two places. These were people who had not presented to any of those settings, even though they have been ill for quite a while, as you will see in the various. So these are some of the characteristics that make this study really quite interesting in terms of what we can learn from it. And these are the sample characteristics of the patients, both in terms of the age, gender, and also in the distribution of the diagnostic categories. As I mentioned, we were also interested in tracking how long they've been unwell for before presenting. And so you can see a very striking picture here that the mean duration of untreated psychosis in India was more than 7 years, almost 8 years, and about 3 years in both Trinidad and Nigeria, where in any case, most of them did make some attempt to seek care in Ibadan, both from traditional and public service settings. But in India, as I mentioned, a lot of them were not in care, and they have been unwell for almost 8 years by the time they were recruited into this study. So let me give you a few findings from the physical health. My colleague, Gerard, will be talking about the profile of use of substance, especially cannabis, in the setting. So we were interested in tracking this physical health, and we used these measures listed on the slide. So we measure their blood pressure, they took blood for blood glucose, lipid profile, and we tracked some selected infection, and did their BMI. So when I talk about malnutrition here, really I'm talking more about undernutrition, because that really was what we found. So that was we define as put on that slide. So basically, this is the profile of the distribution of the physical health in terms of hypertension, diabetes, hyperlipidemia, and head injury, as reported by the. And you can see that the patients in Trinidad had a significantly higher rate of all of these conditions than the ones in Ibadan and India. The reverse is let me see, I think I've gone too far. Yeah, so the reverse is what you will see when it comes to infection, malnutrition, and anemia, where now you find that the cases identified in both in Ibadan and India had a much higher rate of all of those conditions. So hypertension, hyperlipidemia, higher in Trinidad, but infection, anemia, and malnutrition, mainly undernutrition, much higher in Ibadan and India than in Trinidad. Now, I didn't mention that for these cases, we identify controls. So that these were individuals without psychosis who lived in the same neighborhood as the cases and had about the same age of the same gender. So we had some kind of case control comparison of cases and controls. And the findings will be what I will be presenting next. And then in Ibadan, we find that basically no difference between the cases and control in terms of cholesterol, diabetes, hypertension. In India, the same was true, not a lot of difference between cases and control for those conditions, and also the same for in Trinidad. So this indications of a lifestyle and dietary profile, habit, cholesterol, diabetes. But when it comes to Infection, again, now striking difference was seen in Nigeria, where the cases, they were much more likely to show evidence of infection, to be anemic, and then to have to be undernourished in terms of malnutrition that we define there, significantly so compared with control. And the same was true for India, even though that difference was only significant in terms of undernutrition, which was much higher among cases. These were, as I mentioned, incident cases that had not been in receipt of any kind of treatment. No different in Trinidad in terms of those conditions, inflammatory protein, anemia, malnutrition, and infection. So basically you see that in terms of the countries, Trinidad, it was a much higher income country than the other two, had a different profile of physical health condition compared with Ibadan and Nigeria. And these reflected more about the social circumstances of those two countries rather than any kind of previous exposure to treatment. So that is something that we are going to be trying to focus on when we do the analysis of the 2-year outcome, the data of which we already have. And as I mentioned, we are now collecting data for the 6-year outcome, and we're going to see how this pans out. And the reason why all this is also very important is in the context of what Tim has described, which is that we are now able to expand this considerably with PAD, and to see to what extent some of these differences also had some kind of genetic underpinning, which a much larger sample will allow us to begin to explore. So my colleague will be talking about what we found in terms of the use of cannabis and how that relates to the occurrence of psychosis.
Okay, good morning, everyone. Thank you for the opportunity to talk about our work in this context. Thank you, Tim, for the invitation. And to follow up on what my colleague, Professor Gureje, said, the Intrepid study, in seeking to compare these diverse settings, also sought to distinguish in terms of the factors that are associated with psychosis, what might distinguish the various sites. 2 points about Trinidad. One is that it is a relatively ethnically diverse country, specifically having equal percentages of descendants from Africa and southern India. So our population is approximately 40% African, 40% Indian, and 20% mixed and European and Middle Eastern. So in that sense, it also allows for comparison to source populations, so to speak, in India and Nigeria, to look at the incidence of psychosis and how it compares in ethnic groups. And of course, this relates to the comments of the chair, the head of psychiatry here, about disparities in the incidence of psychosis and schizophrenia. And particularly, as Tim mentioned, the fact that these disparities seem to be linked more so to immigrants from the African diaspora as against immigrants from other countries. So one of the factors that emerged from the work in psychosis is the use of substances, specifically cannabis. So that's what I'm going to talk about in the context of the rates. You would also have noticed from Oye's presentation that the rates in Trinidad were quite higher, significantly, to a significant extent compared to India and Nigeria. And again, we've been trying to explain why that might be so. Right. So, well, we has already talked about the study itself, the inclusion criteria being the adult population resident in the catchment area in the presence of a psychotic disorder as defined by ICD. The instruments in terms of those that are relevant to this discussion, the symptom and diagnostic instrument is the scan. We also use the socio-demographic schedule from the Medical Research Council in Britain. And for substance use, we use the ASSIST questionnaire, alcohol, smoking, and substance involvement screening. And you see outline of the ASSIST, the questions that are asked below that. And the exposure variables we looked at were lifetime cannabis use, the frequency of cannabis use, a high ASSIST risk score, and the age of first use. All of these have been associated with psychotic presentations, hence the choice of those particular measures for exploration. And on the left, you have, well, your right, my left, you have the statistical analyses that were conducted. And these were the results. So, as you see, the rates of psychosis were considerably higher in the sample from Trinidad, 59.1, compared to 20.7 in India, or Kanchipuram, and 14.4 in Nigeria. Even there, there's some interesting disparities. In India, you will see that, and which is unusual for most psychotic epidemiological samples and studies, higher rates in women compared to men. And in Ibadan, you see almost similar rates between men and women, whereas in Trinidad, the rates in men were significantly higher than the rates in women. Also, interestingly, in Trinidad, the rates among the population of African descent was significantly higher than the rates among those of Indian descent. And just to go back to the disparities literature, one of the things that started me off in this area was working in London in the 90s, and there are startlingly higher rates among patients of African Caribbean descent compared to patients of Indo-Caribbean descent, as well as patients from the Indian subcontinent in Britain. And this is what led to a lot of the work that subsequently happened in the rest of Europe regarding these rates. So the question, of course, is there some particular predisposition to psychosis among the African population compared to the Indian population? Although the results from India and Nigeria don't support that. So this now looks at the age of onset, and again, the age of onset was highest in India and lowest in Trinidad, with the rates being, in terms of mean age of onset, being lower as well for the African population compared to the rest. And this is prevalence of cannabis use. Again, you see significant differences between Trinidad and the rest of the sites, where 72% of the cases had a history of cannabis use. But what is also interesting is that 65% of the controls also had a history of lifetime cannabis use. So although the percentage in cases was higher, there was also a significant use of cannabis among controls. Again now suggesting that the people who develop psychosis, there are particular variations within them that would lead them to develop psychosis compared to controls, or perhaps protective factors acting among the controls that would prevent them from developing psychosis. And for frequent cannabis use, and frequent cannabis use here refers to daily use. Again, significant difference between Trinidad and the other sites. Also much more so in men compared to women, much more so as well in Afro-Trinidadians compared to Indo-Trinidadians. Interestingly, in Ibadan, you would see that in terms of frequent use, again, it was also seen almost entirely in men, and there were no women who reported frequent cannabis use. And of course, just to go back here, you see in Kanchipuram specifically, there was very little cannabis use. Again, we're not clear whether this is a local anomaly, and whether in other areas or districts in India there might be places where there's higher cannabis use, but certainly this was a striking finding here. And then the association of cannabis exposure with psychotic disorder. So comparing Trinidad and Ibadan, so we eliminated India from this analysis because, of course, as I said, the rates of cannabis use were so low in India. And as you see, those who use frequently, those who had a higher assist score, and the age of first use being less than or equal to 15 years, were all significantly associated with psychotic disorder. The numbers in Ibadan precluded any significant assessment of the effect, but certainly in Trinidad it is clear that both frequent use, a higher assist score, and early age of first use, which all have been identified in the literature as being associated with psychotic disorder, bore true for the Trinidad sample. And again, association of cannabis exposure with the mean age of onset, and you see that those who had psychosis but never used, the mean age of onset was older, 30. Lifetime use, the mean age of onset was 25. Frequent use, the mean age of onset was 24. And those with a high assist score, the mean age of onset was 23, showing that the use of cannabis seems to predispose people to develop psychosis at an earlier age. And again, we saw a similar pattern in Nigeria, although the differences between lifetime use, frequent use, and a high assist score were not that significant, but certainly different and much lower than for those who had never used. So, what does all that mean? There's a high prevalence of cannabis use in Trinidad, higher prevalence among males and the African Trinidadian population. First-time early age users are at much greater risk. The assist score is a useful tool for identifying risk. Based on the interview, many people, or a significant number, 16% of controls, 37% of cases, had previously tried to stop but were unable to. There's also high co-use with tobacco. So therefore, the use of tobacco and attempts to deal with cannabis have to coincide. And this is not the first study that has identified cannabis use as a concern. In Jamaica, Frank Knight and his colleagues way back in the 70s, Frank Knight and Timothy Harding published papers related to what they described then as ganja psychosis, which was Knight's paper, and Harding's paper was called marijuana modified mania. And while it wasn't an epidemiologically comprehensive study, they identified the presentation of young males especially who were presenting in disproportionate numbers to the psychiatric services then, the psychiatric unit at the University Hospital in Mona, Kingston, Jamaica, with high levels of cannabis use, and this being a factor seemingly that had predisposed them to develop psychosis. So the association does suggest that cannabis use is associated with the incidence of psychosis. So one of the other questions is whether this is one of the factors that has predisposed the population in Trinidad to have such a higher rate of psychosis compared to that seen in Ibadan and Kanchipuram. And again, this is just reiterating those points related to the age of onset and the frequency of cannabis use. This is a slide about the prevalence of affective psychosis. So one of the other issues in this whole debate around the incidence and variations in incidence of psychosis is whether it is specific to schizophrenia within psychosis or whether it applies to all psychosis, and what are the differences between non-affective and affective psychosis. And again, you see here that the rate of frequent cannabis use in affective psychosis is much higher in the population in Trinidad, although the disparity between the various groups is not as great. In fact, for women, there are higher rates of cannabis use, and the differences between the Afro and Indo-Trinidadians is diminished quite significantly. So again, it does seem here that the use of cannabis has a different effect, certainly in terms of gender, and perhaps also in terms of the ethnic distribution that we saw for non-affective psychosis. So, wide variation of incidence between the sites with the highest rates in Trinidad, high levels of lifetime and frequent cannabis use, and its association with psychosis in Trinidad and to a lesser extent Ibadan. Looking at previous studies, we found that this was very consistent with the European study, which also reported high levels of cannabis use in the areas with the highest incidence of psychosis. So the hypothesis is that cannabis use may account in part for the variations between Trinidad and Nigeria. And of course, this is speculative, and one of the interesting areas is whether there is a genetic component here that either one predisposes some people to develop psychosis in the context of cannabis use, or indeed is it that the genetic risk or the genetic predisposition has a joint effect in terms of the people who have that genetic predisposition are also more likely to use cannabis, as well as more likely to develop psychosis. So with that, I'll stop there. Thank you very much.